Okay, we started to record. Please note that the information and opinions shared on this discussion and presentations are not intended as medical advice. It's important to consult with a healthcare professional about your specific situation before making any decisions related to your health. Everything you say will be made public. So if anyone's not comfortable with being on camera, that going public, or anything you say, please avoid that. And with that, I think the disclaimer's out of the way. We're recording, so all very good. I'm thrilled to introduce Gitte Pedersen, if I'm saying it right. I'm sure I'm not, but I looked up. Oh, please correct me.
It's Gitte. I know the Danes pronounce things in a funny way. So it's
No,
just
no, in a
Gitte.
great way. Southern California, we have our own little slang bubble here, but you are from Expression Genomics, and I am really excited to hear your presentation. I am very enthusiastic, as I mentioned right before you joined, of RNA-seq interpretation. So really looking forward to your talk and learning about your company.
Fantastic. And I'm going to start out saying thank you for inviting me. I'm excited to be here. I started my journey inspired by two things. One was I have a love for science, come out of a family of scientists and engineers. I remember the first time I heard about DNA, I was like, yeah, that's so cool. I want to study that.
You have an engineering degree?
Yes, yes, I'm a chemical engineer. So on my father's side,
love engineers.
Yeah, they're all engineers. He was an electrical engineer, and they also entrepreneurs.
I'm an electrical engineer.
Right. So engineers, we just like to build stuff, right? So we find technology a problem, and then we build solutions. I co-founded Genomic Expression with my brother, Gitte Pedersen. He's got a PhD in genetics, and between the two of us, we kind of, I'm the closet nerd. He's a real nerd. I raise the money. He spends it in the lab. And there's always this positive sibling rivalry. He's got a PhD, I don't. But he's really deep wet lab, next generation sequencing chemistry nerd, and have developed all the chemistries that we are using on our platform. And I think the pivotal moment for us was really when our parents, both of them, got diagnosed with lung cancer, and they smoked. Back then, people smoked in Denmark. It's better now. And the frustration we had, knowing that they were facing what I call evidence-based death, because there was no cure, and if we just did what we were supposed to based on what the doctor said, we're not gonna, they wouldn't live very long. So I had the opportunity of working as an advisor for the Danish Minister of Foreign Affairs, and I knew all the big shots in Denmark. Jesper Zeuthen, which is a pioneer in immune oncology, and also started the Danish Cancer Institute, etc., etc. So we were able to get my mother into a clinical study. Enough about that. I want to show you what we built, because I think that you understand now that I'm really as much a patient advocate as I'm a technology developer and business person. I truly want to change the way we diagnose and treat patients. And the reason is that, and most of you on this call know this, standard of care doesn't help all patients. In fact, only 1 out of 4 cancer patients live longer if you just do standard of care. We focused on RNA, and actually there's a couple of slides here I should have started out with, because why RNA? It's a quantitative measure of what's going on. It's the phenotype, it's quantitative. And by analyzing the RNA, we can read the program that the cell is operating under and determine whether the cells are healthy or they are sick. And what is really cool is that if the program tumor A is running and there's a drug working and it's effective in tumor A, and we find the same program in tumor B, then there is a probability that this drug that is now approved in tumor A could work in tumor B. So the problem with making RNA sequencing possible in real clinical samples is that it's not stable. It's not supposed to be stable. It's a dynamic molecule. You have to make it quantitative because you have to compare it to something in order to say whether it's high or low. And in a research setting, you can get a second biopsy from the patient, and that's not possible in a real clinical setting. And by the way, adjacent normal is not real normal. We have a publication on that. And finally, we had to translate how, once we have a list of abnormal expressed genes, what do we do then? How do we translate it into other treatment options? And by the way, please ask questions, okay?
Let's stop for a quick second. And
yes,
I invite our patients to weigh in on their background. Does this make sense to you guys? Is this over your head? Is this right in the sweet spot? Where
No, it's fitting for helping me better understand some of this. I mean, I've had my own RNA sequence, and even though I don't understand everything that's there in the report, this is kind of putting the pieces together for me.
Awesome. I like to hear that. I try to make it as easy to understand as possible. And I know once you are a patient, you're being thrown into all this new vocabulary, and you have to catch up and understand what progression-free survival means, right? So here we go. RNA is destroyed in real clinical samples because the way you treat tissue is that you dunk it in a formalin and embed it in paraffin, same thing you make candle eyes out of, in order to slice it up and color cells and look at them under a microscope. And this technology is 50 years old, and we're still doing it. And we diagnosing cancer based on looking at abnormal cells under a microscope. So we had to develop proprietary chemistry to enable RNA sequencing in these samples because it's very fragmented, meaning chopped up in little pieces. And then we had to compare it to something, and we created a database over normal RNA expression ranges in normal tissue. And so here we go. This is a little bit of science plot here. You can see that the green is true normal, and the orange is adjacent normal, and the blue is tumor. So if you take a second biopsy from the patient, it's closer to tumor than normal. We don't need that. And then we do some math to, it's called a box plot, to figure out if it's significantly over or under expressed. And then in order to translate that information into a report, we define a list of already approved drugs that targets ligands and biomarker for selection of that drug. So to give an example, for instance, PD-L1, which you probably heard of, is inclusion enrichment marker for checkpoint inhibitor. We can measure that. That's a ligand for the drug targeting PDL. Okay. And then we put it all together and clinically validated it from the sample acquisition all the way to the report in bioinformatics background. So you can send us a sample and we can give you a report back in a reasonable time frame.
Is this
And
tissue only?
I will get into that because we have some ideas about liquid biopsies. That's a great question. The technology itself is not limited to tissue, but every time you move it into a different biospecimen sample type, you have to validate that sample type. Does that make sense? And you need to know what normal ranges is in that biospecimen. Okay, so we need to build a database. Okay, so this is the total technology stack. There's a few more pieces to it because during COVID, we also created a virtual care platform where we connect the doctor with the physician and the sponsor of a clinical study or a testing program. And the patient have access to that data at the same time as the doctor has in this platform. And on top of it, we're putting some machine learning capabilities because we are not using panels. And that's one of the big differentiators. We are uniquely identifying and quantifying all messenger RNAs in a sample. And we typically find a handful of markers for response to an already approved drug in all the patients, and believe that by incorporating that into the clinical decision-making process, we can hopefully improve outcome for most patients. And if you look at DNA panels, the big ones, 500 genes, they find one actionable marker in 40% of the patients. In a late stage setting where 20% response is a good number, that translates into better outcome for 8% of the patients. Okay. And so we believe that we are on this tipping point where we need to move away from the static treatment model where we have one disease, one marker, and one drug. And this is the poster child, Herceptin, where HER2 is really just an enrichment marker. And the response rate is 50% in early stage and 20% in late stage. And we could still call that success. We believe that we need to truly individualize treatment, one patient, many biomarkers, and multiple treatment options. And then it's a matter of sequencing these treatment options, they stack them or combine them in the right way to improve outcome. So this is just a one patient case story. Medullary metastatic thyroid cancer with no treatment options. And we were able to find a very overexpressed RET, and that is a 3' fusion partner to fusion in the NTRK gene, where we found a drug in development at that time, which is now approved. And some of these drugs targeting fusion genes are very effective, so 70% response. And she's in complete remission 3 years out. So that's a fantastic story. This is just another data point where we in silico can combine different drugs. When I look at the pipeline of drugs in development, I find it rather random what they decide to combine it with, instead of doing some statistics on how can we improve outcome by combining with the right drug. So the last thing I would say is that
Could you go back to that slide, please?
Yeah. Yeah.
This is a lot of information. It's hard for me to take it
Yeah.
all in.
So they don't look at all the colors. If you
Okay.
look at the numbers, you can see the penetration of overexpressed PD-L1 is I think 37% and 25%, and CD19 is not 37. So if you combine those two in this tissue, you could potentially get a response in 17%, or enroll 70% of the patient population. And if this is a design of an umbrella study, so you have a checkpoint inhibitor with 3 tumor antigens. And this is possible to enroll because you address more than 20% of the patients. Mutations have single digits penetration in different tissues, and those are very difficult to combine because let's say 5% of one marker, 5% of another, 5% multiplied with 5% is 0.25% of the patient population. Finding 0 to 5% of all patients is difficult.
Thanks.
Okay. So the last thing I would say, and this is just hang in there, because I think we are getting to a point where we are able to individualize treatment. RNA therapeutics is expanding rapidly, not just RNA vaccines. Clearly, RNA vaccines are now in development for cancer. But because of the very short time frame from code to product, and I'm talking about months here, we, instead of trying this out on 10,000 patients, if it works for you, that's good enough, right? So I can see in the future that we'll be able to individualize RNA vaccine production for patients. And we have a separate company that is doing enzymatic DNA printing, and you can translate DNA to RNA pretty quickly. So we can see that coming. And then the last thing is really, and that's something I think is super important, that we all understand that the rubber hits the ground when we combine our collective information with clinical outcome data to inform ourselves, but also other patients and pharma companies, how to better treat and how to better develop drugs. So at the end of the day, we would like to develop response algorithms, and there's a whole list of algorithms already developed on RNA, just using older technologies that can predict based on your biomarkers whether you're gonna respond to a particular treatment. And I'm starting out with standard of care because I think one of the biggest questions anybody with cancer has, is this gonna work for me? And then if it's not gonna work for you, then you should have another option, and that should be having access to repurposing existing drugs. So that's again, you know, my vision. We're not quite there because it's a lot of we have a clear lab, we can receive samples now, but in order to develop these algorithms, we have to collaborate with hospital systems and also patients. So so that's where the big data comes in. And these are just some of the algorithms. It's not just in oncology that have already been developed using RNA. Most of these are on PCR, but also on the older gene chip technology. MammaPrint is using gene chip. And so also from a regulatory standpoint, there are some changes because there used to be this binary relationship between one test and one treatment. but that have changed. Oncomine DX advises patients to test a number of genes and have a number of options in terms of drugs. And another change is that one drug is being tested in many different tissue types at the same time. And the first one that was universally approved based on a biomarker was larotrectinib for solid tumors. And that was exactly with the case story that I showed you with the gene fusion. So I think I'm gonna stop there and take questions. We won a lot of awards. We got to where we are for mostly grants. And we located north of Boston at the North Shore Innoventures. That's where we have our lab. So not too far from downtown Boston. And these are not our numbers, but the collective this is an incubator, been very effective in maturing companies. All right.
I got to say that was a fabulous presentation. It's so
Thank you.
intriguing and so hopeful. So I'll open it up to any questions that folks may have.
Maybe I'll get us going. Hi, Gitte, Brian McCloskey. Thanks so much for your presentation. It was really on the mark. It helped to fill in some blanks in terms of how we think about using RNA in developing treatment options. So thank you for that. It's encouraging to see that the translation of RNA-seq information into a specific treatment for a person or a cancer is down to 12 months. However, particularly for cancer patients who have been exposed to several different therapies, our cancer can change pretty quickly. So I know that my genomic profile has definitely changed within the past 12 months.
Yeah.
How does your solution kind of fit into that kind of dynamic environment?
Excellent question. So one thing I say, we want to know if the treatment works for us, but we also want to know for how long, and then we want to monitor that in a liquid biopsy, right? So we're moving away from this very static treatment modality where we just treat everybody the same. And we need to have those monitoring methods, not just the scans. The scans are great, but we get those scans every 3 months, and a lot can happen in between those two data points. We are not quite there in terms of being able to launch a liquid biopsy for cancer, but we're working on it. And the way we're thinking about it is obviously blood is one biospecimen, but we're also looking at self-collected samples in saliva and urine. And both of them are super interesting. We worked in urine before in bladder cancer, and you could potentially also detect prostate cancer in urine. So, pee in a cup, send it to us, and we will know how it is. Send it back to you, and then if your marker starts climbing up, you go to the doctor, you get another scan. So that's how I see it going forward. Saliva is also a very interesting biospecimen. It's actually one that we potentially could detect lung cancer, head and neck, and also surprisingly breast cancer. And there we have the same idea that we can ship the collection tube or collection device. It's spit in a tube, pee in a cup, spit in a tube, send it back. You will have access to the data on the platform, be notified at the same time as your physician, and will know if the biomarkers are going in the wrong direction. Okay, And that information, you probably heard about liquid biopsy, but there is a potential that that information could also translate into treatment guidance without a second biopsy, but that's something we don't know yet. But that would be wonderful, right? If we could collect enough information from those biopsies, then we will be able to do that.
Sure, I think the promise of liquid biopsies is intriguing to us. The heterogeneity of our cancers makes tissues sometimes a challenge. I just had a biopsy in August, and then I had a full resection 3 months later, and the genomic profile was different because the biopsy only captured a portion of my tumor. So these are real world challenges. But the promise of liquid biopsies are something that we certainly understand. Thank you.
Yeah.
As trying to fill in for Brad, I want to invite more questions, and particularly, I'm sorry to call you out, Emma, but I think you're, my shining star, our guiding light here. And did you have any comments?
I think you muted. Yeah.
Emma, you're on mute. Emma, you're on mute.
I'm sorry. As I was saying, I'm not quite well these days, but that will pass. I am a big fan of RNA technologies. The only problem I always have is that sometimes RNA data do not agree with the protein data. And after all, we target proteins. So I am almost a bigger fan of proteomics, or the fact that the RNA overexpression data have to be confirmed by protein analysis of some sort.
Right.
So
I'm a big fan of proteins.
Trivial observation, yeah. But
and what I will say is that the technology for proteins is just not as scalable, and proteins, and not as affordable either. If you want to test everything, right? But there's definitely a lot of rationale behind doing a validation, and we've done that with some of our findings using IHC. So that was how we did it. We validated up against ERPR, HER2, PD-L1, and the endocrine receptor, and we have very high concordance with those.
Most of the time they jig the data, but I've seen cases where they don't, and that's very disappointing. RNA is sort of it's more precise, but I always like to see a confirmation of protein presence, which is easier once you know the few targets that need to be confirmed.
Exactly. So again, just because I have one tool in my toolbox doesn't mean that the other tools can't work in combination. I have a hammer, somebody else have a nail and a screwdriver. And so I think that the way I think about it is that we can put a list of potential things in front of you, and then you will, it makes a lot of sense to validate afterwards. For instance, for the fusion gene that we flagged, we don't have the FDA approved assay to confirming the fusion. And so going to another lab and get that done is making a lot of sense to me before you dial into that. We may at some point just choose to have the validated assay in-house, but that's something to think about. But if you just said, if you wanted to test everything, nobody doing that right now. So I think we are the first net that you cast, and then you narrow it down to a subset of relevant biomarkers, and you can always validate those, also on the individual patient basis.
Okay. I noticed that Eric has his hand raised, so I'd love to hear from Eric.
Yeah, I guess my question is around access. How could one of us as patients access your testing, right?
Yeah. So the problem with all diagnostic companies is that it takes a long time to get payer support. There is a payer code for any next-gen sequence-based test. It doesn't define whether it's RNA or DNA, as long as it has more than 50 genes. So technically, you should be able to get your insurance company to pay for it. It doesn't mean that they will, right? So number one, you need a physician order, and then you need, we can't take the risk of the claim not being paid because we haven't raised a lot of money yet. But you will be able to submit it if you have a doctor's physician's order and the test is done, then you can submit the claim.
So you saying you can only access this if you have insurance approval?
No, I did not say that. I said that you can pay out of pocket and then you can submit it to your insurance. There is a payer code. And if the if your physician have ordered it, then there's a chance that they will pay it. But it's not something we can guarantee, or, it's impossible to say. We would like to work with payers, and that's a project in its own, to get them to understand that if we treat patients with more effective drugs earlier, they don't progress, and we will all have better outcome and reduce cost. But that's a clinical study that we need to prove, and we have to measure all these factors. We haven't done that yet.
So yeah, the whole insurance thing is difficult. I mean, I've had whole exome sequencing and liquid biopsies, and insurance has balked at paying all of those for me, right? So, I mean, I'm interested in this. Is there like a ballpark, a figure amount of how much it would cost out of pocket to use your service?
Yeah, we're charging $3,500 out of pocket per test, and so we're trying to make it as affordable as we can.
And and so maybe I missed this on your slides earlier. Does it require live tissue?
No.
Okay, because you were talking about the tissue that was treated with, it said FFPE, I think was the term.
Yeah. That's how, when you get a biopsy or you get the tumor resected, the tissue gets embedded in paraffin because they slice it up and look at color cells on a microscope, and that destroys the RNA, but we can handle it. So if you have if your institution where you got treated have any tumor left, you can send that to us, and then we'll analyze it.
Okay, so you could use maybe like biopsy cores that are still left, or from a surgery. So I'm having surgery in 2 weeks. That's why I was wondering about the live tissue, if I needed to try and arrange something like this, or you're saying it could be done after the fact from the tissue that's remaining after surgery.
Yeah, we actually prefer the FFP now because we have an idea of how much tumor there is in the tissue. And that's important because if you dilute the numbers with normal, as you can see, we're comparing to normal. So it's better that we understand exactly how much tumor we have.
So I have one more question, and I might need some help from some others on the phone here, like I'm thinking Brian or Emma with this also. So we've talked to some other people on this group, like Robert Nagurney and Sinjin, that do what I call functional testing. There's probably a better name for that.
Right.
I guess I'm wondering what you're describing here, how that's different from what they do.
That's a great question. I actually like functional testing a lot, especially for chemotherapies, because I think that's where they shine, and possibly also for targeted. But the minute you have the tissue somewhere else, it may not respond exactly the way it does in your body. So that's the only thing I will say. I will also say that for immune therapy, I haven't seen any functional test that you can do there, and so we can see the difference between a hot and a cold tumor. And also now there's more than one checkpoint inhibitor, which one is in play for in your tumor. So I think they're synergistic. What I would suggest is you do an RNA analysis first, and then you narrow it down to a subset of drugs. So you can do the functional testing in a subset of drugs. And we actually have a collaboration with the NCI in metastatic colon cancer to the liver, where they're doing that. But in that model, you only have 10 shots on gold, right? So you have to come up with 10 drugs or 10 combinations. And this is my last one. I'm a big fan of combinations. I think understanding the pathway and understanding, for a resistant mechanism and understanding how to close those doors.
Maybe I'll add some color, Gitte. So Eric, with functional testing is really just about trying to predict whether or not a drug is going to, effectively treat your cancer. And Sengen, for example, builds organoids, and they do specialize in chemotherapy, not just chemotherapy, but that's, I think, where they've had the greatest success. And then with Nagurney, he's using assays, so he's not using an organoid model, but it's to the same, with the same intent, is just testing whether or not a drug that you may have targeted actually is going to work. Again, it is ex vivo, so there's some challenge. But if you are thinking about going down that route, it does require live tissue. So you'll need to work with your care team like ASAP to figure out, who the vendor or vendors are that will take your tissue, your live tissue, like comes out of the body, goes in the cooler, goes in the igloo, and gets shipped off, right? So, and then, that of course requires that pathology is integrated into that discussion. As I unfortunately discovered, there's a lot of moving pieces to make that work. But anyway, we can talk offline if you want to.
Yeah. So Brian, actually, that's kind of why I asked this question, because I talked to both Nagurney and Sinjin about this with mine, and there's a ton of logistical challenges around actually getting the live tissue to them, right?
Yeah.
As you experienced. So this, with it being, being able to use the tissue later seems to eliminate some of that challenge around the issue that you had of getting that live tissue straight from the operating room, right?
Here's what I'll say is that you don't have a lot of shots at getting live tissue. Like, I'm pretty much done, might be able to get a biopsy, but in terms of like localized treatment for me, that's pretty much off the table now. So I would do everything that you can to try to get some type of functional testing, whether it's Sengen or whether it's somebody else. Sengen sent me a box, so I could have gone with them, but I didn't. I went with another vendor. But you just need to make sure that I would go through your medical oncologist and let him or her piece together all of the back end operational components to get it where it needs to go.
Yeah, that's fair. I don't want to get us derailed on that
Yeah.
here.
Yeah. We
No,
can
I-
talk-
I-
conversation, so I'll let you
I
go
will
back.
just encourage all of you to be your best advocate. And when I gave birth to my kids, I insisted that we collected their the blood code stem cells. And so, that's kind of a little different situation, but kind of the same. And you're gonna have to do that. And it is synergistic. And if you are considering adding, when I say combo, I'm also meaning the right chemo with the right targeted or the right immune therapy. It's good to know in advance that you're losing your hair for a reason. Okay, and it's working on the tumor, and then understand that, as you also said, that can change, right? So it develops these resistant mechanisms, and maybe understand if you have other biomarkers tested, do the literature search. Is that related to lack of response to this particular drug? It just had one trend where retrospectively she should have chosen another route, but the data wasn't there when she made the decision.
Awesome, thank you.
Yeah,
I'll let some other people comment.
Yeah, let's open the floor to anyone. And if no one, I'm going to shamelessly, okay, perfect, James.
Yeah. So my question's pretty rudimentary, but would you be able to kind of sketch out what the milestones are on that 12-month timeline?
So I just want to make it very clear that it's 12 months for a vaccine, but we're not there yet. We're still building that machine. But for the test where we use already approved drugs, where we repurpose existing drugs on an individual patient basis, that's something we do now. So there's a difference between now and the future. And the translating code to drug doesn't have to take 12 months. I think we can do it faster once we build the machine, but we're still playing around with the technology and making it work, because you want to make sure that the code and the vaccine is completely accurate, right? And we know how to determine that. So that is in the future. That will take years before we're there. What we can do now for everybody is repurposing existing drugs on an individual patient basis and come up with some ideas to what to combine. We're not testing for chemo. That's why I think the functional assay is supplementary, because that will give you a good idea whether your tumor have become chemo resistant, or if there's other chemos that could work for you.
Well, thank you for that clarification. I appreciate that.
Yeah. And I'm interested if Rick or somebody could send me a list of the functional guys. I have some contacts, but I think because I believe there is a reason why we should work together. Yeah, I would love to get in contact with them.
Sure, I'm happy to work with Brian and Brad to get those to you. I do notice that we have some brilliant folks in the audience, and I'm shamelessly going to call on a few of them. I'm going to start with my pal, Allie. I don't know if you're able to comment, but I think the world of you, and you're such a genius. Do you have any comments here?
Oh, hi, you're so kind. Yes, I can comment. I think this is really important and very interesting, and I'm always looking out for how various omics other than DNA can enhance therapeutic recommendations or inform the process. So we at CureMatch, we can take any kind of data, but we do require that it's something that is clinically relevant, and that judgment is something we stay away from making as much as possible. So the clinical lab or the care team have to tell us to take something into account as pathogenic and or actionable. So things can be non-pathogenic but actionable, such as PD-L1 expression. PD-L1 is not pathogenic, but it's actionable for triggering immunotherapy considerations. And then there are those things that can be pathogenic, but nevertheless, there is no drug out there. They're not actionable, but we take that into account. So anyway, as long as the determination can be made and it's a CLIA grade lab report, even if it says research use only, but the care team is okay with it, and it's a CLIA grade lab that produced the report, and interpretation of this, clinical relevance is there, then we can actually take it integratively with all other omic results. So I'm always looking out for these things. And you remember, guys, there was a presentation by Shino of mProbe. Does anyone recall? Rick, do you remember? Proteomic stuff?
Yes.
So we're partnering. We're actually, in partnership now.
Great.
And because so they produce proteomic level results, and that can inform therapies. And here's the thing, I think that sometimes people think that because they got DNA results, they give it to us and they're going to have all kinds of therapeutic options. But sometimes there may be just one mutation, one marker of sorts, and it's not actionable. There are no drugs out there. So we don't have anything to really cure match. And especially in those cases, we can absolutely, refer to these types of companies, whether it's protein or RNA level based testing, to say, look, if at least you could get RNA profiling done, protein profiling done, then you may have some other options to explore, because on the DNA level, we can't even match anything. So at least that's one of the kind of synergistic opportunities, and vice versa as well. So things can be where you see a patient or a physician that has patients that have a lot of complexity going on. And besides RNA or protein results, there's also several DNA panels, and how to reconcile all that. So then all that can come to us, and we basically take all that data integratively and produce a cure match report where we rank and score therapeutic options, including combinations and monotherapies as well.
So Ali, we should definitely talk, right? I think that sounds fantastic. That sounds fantastic.
Yeah. Thanks, Ali.
Very open to that. We'll let's connect. I'll find you on LinkedIn right now.
I know. I looked up Gitte as well. Jeff, I see you have your hand raised.
Yeah, I'm dating both of us. Gitte and I met probably at I think a Faster Cure Summit about a decade ago, believe it or not. So
that's probably true.
We were both 10 years old at the time, though, so it wasn't that long ago. But two things to bring up. One is I'm going to reach out offline about reimbursement. I worked for Aetna for years, so I'd like to talk to you about that. I'll send you I don't know if I have your email address. I think I do, but I'll connect with you on reimbursement and maybe some ideas.
Yeah.
And,
I would love that, because that's a big, I'm going to text my email in here, and
I think I have it, believe it or not.
Oh, beautiful. We just got it in the chat.
Okay, so then the other thing is, so a separate topic, but I've been working a lot in the last 3 years on expanded access programs. So one thing I'm focused on is getting patients, particularly ones with later stage disease, access to investigational therapies.
Yeah.
Almost none of them would qualify for clinical trials because they're too far advanced. So they want the drug to get approved. So they pick patients that are relatively early in the stage of disease. And so in a way, I think it's a blessing. And because then you're not going to get in the placebo arm of the trial either. You're going to get investigational medicine. It's still, cost-free to the patient in terms of the drug itself, not necessarily the associated medical costs. And so one of the things I'm hammering on, obviously it benefits patients because they can get accelerated access to investigational medicines. I'm working right now with a bladder cancer patient who's got like 5 months left to live, and he's looking at an investigational medication for him. And he was a 30-year pharma executive also, so he knows the system. But I'm co-chairing the past 3 years of Summit on expanded access. This year's the first time in person in Boston. It's third week of March. And I'm running a patient panel workshop the day before the Summit too. So I might just send to Rick and Brad the link, and you can get it out to everyone if you want. So the other thing I'm hammering on though is it not only benefits patients, obviously the payers like it because they're not paying for the therapy, and they want to help, patients that that run out of standard of care.
Yeah.
Providers like it because they're struggling to figure out how, but it's so disorganized, and it has to be submitted via your physician, has to get approved by the drug company and by the FDA. You have to show that both why you're likely to respond to the therapy and how you've exhausted standard of care. So I'm pushing pharma because once their drug is approved, the target patient population probably more resembles the EAP audience than the cherry-picked clinical trials.
Yes, so, absolutely.
But they don't gather any data on the EAP patients. So I'm trying to work hard on, I have a lot of good pharma contacts, work hard and say, look, I know you view the EAPs as kind of a, they used to call it compassionate use. It's not compassionate use, it's brilliant research that will then guide patients long-term that are getting the therapy besides the early stage. I'm sorry, Rick. EAP stands for expanded, its common name is compassionate use, but it stands for expanded use protocol program. As part of the Obamacare, Affordable Care Act, every pharma company has to have an EAP policy. They don't have to offer an EAP, but their website has to state what their policy is. You can actually apply by phone. Your physician can call the FDA on the phone and apply. You have to follow up with a 1 or 2 page document, but you can consider over the phone, get the program started. There's a app that was, it's called the Reagan-Udall app. So that's how old it is. They've created an app that simplifies the process for providers to submit a patient for consideration to the FDA. So I'm getting the red flag here that time's almost up.
You're getting the music at the Academy Awards.
But Jeff, that is so important, right? So
Brian's going to bring the hook on, so I know I'm in trouble. But anyway, those are my brief insights. So thanks for listening, and thanks for joining us today.
Yes, thank you so much.
So Jeff, that is so important. And I'm sorry for bouncing in here, but one of the things that as I said, getting the payer support is one of the next big mountains that I have to climb. And I don't own the drug. So Jeff, we should sit down and talk. I have some ideas on how, because I showed you how to design the clinical study based on, you can do all the statistics in advance. We just got a drug in rare cancers. And rare it's a generous definition by the NCI, everything below 20,000 cases in the US. But because we look at cancer not as where it originated, but as tissue. And some of these cancers that are considered rare don't have an approved FDA approved drug. And that's why we got the grant, so that we can repurpose existing drugs on those patients. And I would like to speak with you because I need to access those drugs. And this is phase 2. We're still in phase A of this grant. But if we do everything we said in phase 1, it's actually a contract. Then I think we can get a clinical study set up.
Yeah. 2 more quick points. One is I'm also doing rare disease, not rare cancer, but ultra rare diseases as well.
Okay.
And I'm also Boston based. So we'll be in touch. Yeah.
Oh, that's fantastic.
You got to go to California to see these guys though.
Yeah.
Great, thanks. We're running out of time, but I did have a question that I hope is pertinent to our patients here. Several of us have our RNA-seq quantified at Tempus. So we have transcripts per million as well as counts. Can you deal with that data?
Oh, great question. We haven't tried, so I don't know, but we're very good at figuring that out. It does require some work because the way that RNA is analyzed by Tempus and Claris and a bunch of other people who just started to add it on is using exome panels. So when you use panels, it does screw up the relative abundance a bit, and you don't have any database to compare it to. So that's a problem with that data. I don't know. We participated.
I think you should be able to normalize.
Yeah. So
that.
that's what I'm saying. I
Maybe
would take a swing at trying it.
I'm happy to provide my data to you.
Yeah.
You
Okay.
know, and that might help your access, your $3,500 barrier. For
because they pay for it, right?
Yeah, the insurance is paid for the Tempus genomics and RNA-seq. So that was
they
zero.
Do that now? What is the reimbursement? Do you know?
My doctor writes a prescription and I never have to pay.
Okay. Yeah, so you don't know
that, you know, and so we're able to get that data. So maybe that can help you. Saeed, thank you so much. I wanted to call on you, and but I see we're running out of time. Brad did tell me stop at the top of the hour. Don't keep going. You know, but this has been a fantastic, lively conversation, and we sure appreciate you coming. And I think there's a lot of connections here that's been made. Brian, do you have any closing?
Yeah, I was just going to say, Rick, maybe what you can do is you can stop the recording because it's going to have to be transcribed. And if we go beyond an hour, then that creates a really long endeavor to transcribe it. But typically, you know, we would